Let me first introduce myself. My name is Dr. Ramon Botumbacal, a professor in the Department of Ophthalmology, University's Ramon Magsaysay Memorial Medical Center. The department was established way back in 1957 at the founding of the College of Medicine. UE became the first center where we were able to put now what's widely used now, the intraocular lens implant. So many accomplishments have been done. And because of this experience, we were now able to formulate a certain modus operandi in trying to devise postgraduate courses aimed mainly for the residents to be, the practitioners, general practitioners, and also the basic courses in ophthalmology for the undergraduates. We are now offering a format on how these courses can be given to be ably demonstrated by the faculty members.
Visual acuity refers to an angular measurement relating testing distance to the minimal object size resolvable at that distance. Obtaining a visual record is very important, considering that the primary function in ophthalmic care is the preservation of vision. Thus, it is obligatory to have a record of visual function on the first examination for whatever reason, and also after treatment, especially after surgery. Distance is commonly tested clinically with some degree of accuracy using Snellen's test types placed 6 meters or 20 feet away from the patient, since the rays of light at this distance are virtually parallel and no accommodative effort is exerted. This functional examination depends mainly upon the patient's statement, so that the subjective response must receive our critical analysis. If different letters cannot be used for each eye, the poorer eye should be examined first, so that the second eye will not have the benefit of visual recall from the first. This is so because once the stimuli of a row of letters are consciously or subliminally recognized in the cerebral cortex, their influence cannot be removed. Ideally, different sets of letters or numbers should be used for each eye, and traditionally, the right eye is examined first. Visual acuity is expressed as a fraction, the numerator of which indicates the distance at which the patient is examined, that is 6 meters or 20 feet, and the denominator, the distance at which the letters in question should be read by the person with a normal visual acuity. Testing distance visual acuity. Number 1, ask the patient to stand up or sit at the designated testing distance, that is 20 feet from a well-illuminated wall chart. Number 2, occlude the eye that is not complained of. Ask the patient to make sure that the occluder is not touching or pressing against the eye. Observe the patient to make sure that there is no conscious or inadvertent picking. Number 3, ask the patient to say aloud each letter or number.
N, C, K, Z, O.
Or name the picture object on the lines of the successively smaller optotypes from left to right until the patient correctly identifies the optotypes on the line. Number 4, note the corresponding acuity measurement shown on that line of the chart. Record the acuity value for each eye separately with correction and without correction. Number 5, when the patient can read up to this line, he is said to have a normal visual acuity, and thus it is expressed as 20/20. 6. If the patient misses half or fewer than half of the letters in the smallest readable line, record how many letters are missed. Like so, in this line, he missed 2 letters, so it should read 20 over 40 minus 2. Number 7. When a patient can read up to this line, it is recorded as 20 over 30. And if the patient can only read the top letter, his visual acuity is expressed as 20 over 200. 8. When a patient cannot recognize the top letter, then the distance for the test type should be reduced, and the visual acuity recorded as 19 over 200, 18 over 200, and so on down the line. Number 9. When a patient cannot see the top letter from any distance, record the maximum distance in feet or inches in which he can count the examiner's fingers, like so, counting fingers at 2 feet or counting fingers at 6 inches. Number 10. If he cannot count the fingers, the examiner moves his hand in front of the eye under observation and asks the patient if he can recognize any movement or shadow, and the vision is recorded as hand movements. Number 11. If the patient cannot see the movement of the examiner's hand, a strong pen light is flashed from the superior, inferior, lateral, or nasal side, or fields of view. If the patient can identify and point where the light is coming from, visual acuity is recorded as light projection. Number 12. If the patient still cannot identify the direction of the light source, but can perceive the light from the pen light or other light source, visual acuity is recorded as light perception. Otherwise, if no light is perceived, vision is then recorded as no light perception. Pinhole is done if the visual acuity is less than 20 over 20, using a 2.4 pinhole. Now, testing for pinhole visual acuity. Number 1. Position the patient and occlude the eye not being tested, as done for the distance acuity test. Number 2. Ask the patient to hold the pinhole in front of the eye that is to be tested. Number 3. Instruct the patient to look at the distance chart through the pinhole. Number 4. Instruct the patient to use small hand or eye movements to align the pinhole to resolve the sharpest image on the chart. Number 5. Ask the patient to begin to read the line with the smallest letters that are legible, as determined on the previous vision and without the use of a pinhole.
C, K, D, and R.
Number 6. Record the Snellen's visual acuity obtained and proceed with the abbreviation. Testing near acuity. Number 1. With the patient wearing the habitual corrective lenses for near and the near card evenly illuminated, instruct the patient to hold the test card at the distance specified on the card, usually 14 inches. Ask the patient to occlude the eye that is not complained of. 3. Ask the patient to say each letter or read each word on the line of smallest characters that are legible on the card. Number 4. Record the acuity value for each eye separately in the patient's chart. Number 5. Repeat the procedure with the right eye occluded and the left eye viewing the test chart. Number 6. Repeat the procedure with both eyes viewing the test card. 7. Record the binocular acuity achieved.
The external ocular examination consists of a three-part stepwise sequence. It involves inspection, palpation,
and auscultation. During inspection, the examiner looks for any abnormalities while examining the patient in the following sequence. First of all, we look at the general fascia of the patient, of course the head and the face. We look at the nose, the mouth, the lymph node, the skin, and the paranasal sinuses. Then we look over the orbital ring, the upper orbital ring, the lower orbital ring, and then the eyelids. Can you look down for me? And look up. And then we look at the lacrimal gland. If there are any growth in the lacrimal gland, any protrusions. And then we look at the globe. Can you open your eyes wider? Look straight, that's it. The next step is palpation. In doing palpation, it involves tactile and proprioceptive and temperate senses on the part of the examiner. A considerate examiner avoids sudden, unexpected touches on around the eye, particularly in patients with poor vision. A screening is done routinely as follows. We use the middle finger and the index finger to feel for any preauricular lymph node. And the preauricular lymph nodes are usually found here in front of the ears. And then also submandibular. And you feel for any particular masses that might be present. Also, using your index finger and your thumb, you can open the eyes to check whether there are any foreign bodies. Ask the patient to look up, look down, look to the right, look to the left. And if you feel that there are any possibility of foreign body on the tarsus, you ask the patient to look down. With your index finger and your thumb, put a little pressure superiorly, grab the lashes and invert it, and then you'll be able to see the upper tarsus. Here, with the use of a good flashlight, you'll be able to see a foreign body. To return this tarsus is just to release and flip it over and ask the patient to blink. Open your eyes, look straight. Another procedure that we can do is we can use again the thumb and the index finger to feel for masses on the upper eyelid. Ask the patient to look down, and then you try to palpate it, feel for any particular presence of masses. The same thing with the other lids, look down and feel for them. Ask the patient to look up, and likewise feel for any presence of masses. Another procedure that you can also check using your palpation is to feel for the presence of pressure, intraocular pressure. Using your two index fingers, you ask the patient to look down. Using your index finger, you palpate by putting a little pressure and make the proper indentation. When you feel for that indentation, you can make a guess, a very wise guess as to the pressure of the intraocular pressure of the eye.
Ocular motility. Eye movements can be monocular, one eye only, or binocular, both eyes together. Monocular eye movements are called ductions, and 6 terms are used to describe them. Adduction, which is movement of the eye nasally. Abduction, movement of the eye temporally. Elevation, movement of the eye upward. Depression, movement of the eye downward. Intorsion, nasal rotation of the superior vertical corneal meridian. And extorsion, temporal rotation of the superior vertical corneal meridian. Binocular eye movements are described as versions or vergences. Versions are normal binocular eye movements in the same direction. Example, to the right or to the left. One muscle of each eye is primarily responsible for the movement of that eye into a particular field of gaze. These two simultaneously acting muscles are called yoke muscles, and their movement is said to be conjugate. That is, they work at the same time to move the two eyes in the same direction. The 6 positions of gaze in which yoke muscles act together are known as the cardinal positions of gaze. They are right and up, left and up, right, right and down, left, left and down. Vergences, on the other hand, are normal, disconjugate binocular eye movements in which eyes move in opposite directions. The 2 primary types of vergences routinely evaluated are convergence, the movement of both eyes nasally, and divergence, the movement of both eyes temporally.
Now we're going to examine the ocular motility of the patient. That means the movement of the eye. When only one eye is moving, we call it duction. When both eyes are moving, we call it vergence. If the movement is inward towards the nose, we call it nasal ward. If the movement is outward, that means it's temporal ward. If both eyes are moving inward, we call it convergence. If both eyes are moving outward, we call it divergence. Now, in examining the patient for its movement, there are 2 methods of examining the patient. One is to get the command movement, and the other is to get the following movement. Now, we'll first ask the patient to follow an object, that is for the following movement. And at the same time, the patient will note whether there is diplopia or double vision. Now, at a certain distance near to the patient, I'll ask the patient to follow the light. I'm holding, going up, up and out, and then down to the right, down to the left. That is the following movement. Now for the command movement, I'll just give the command to the patient. Please look upward, look downward, look to the right, look to the left. Now, the patient's eye moves in good alignment. Then, after that, we'll have to get the near point of convergence. That is to ask the patient to look at the light from a distance, and the light is moved towards the patient. When the patient can converge well after a certain distance, that means the patient can hold, and if one eye tends to move outward, okay, it's moving already, that means I have reached the near point of convergence. Now, to test for the distance, whether when there is movement, if the eye is covered, I'll ask the patient to look straight ahead, then cover the eye and move it out. Remove the cover. If there is movement, that means there is some abnormality, we call it chorea. Then transfer the cover to the other eye, move it alternately, see for the movement. Now, I've seen that there's no normal movement. That means the eye is normal.
Pupillary examinations. The pupil is the window of the inner eye through which light passes to reach retinal photoreceptors. Because of its potential to reveal serious neurologic or other diseases, examination of the pupil is an important element of a thorough ophthalmic evaluation. Pathologic disorders can alter the size, shape, and location of the pupil, as well as the way the pupil reacts to light and near focus stimulation. Performing the light reflex test. Under dim room illumination, ask the patient to maintain fixation on a distance target, such as a large letter on the Snellen acuity chart. Shine a bright handheld light directly into the right eye by approaching it from the side or from below. Do not stand in front of the patient or allow the patient to look directly at the light, which would stimulate the near reflex and preclude accurate light reflex testing. Record the direct pupillary response to light in the right eye in terms of the briskness of the response, graded from 0, indicating no response, to 4+, indicating a brisk response. Repeat steps 1 to 3 for the left eye. Repeat steps 1 and 2 in the right eye, observing for the consensual reflex by noting the response to the light of the non-illuminated pupil. The rapidity of the response and change in pupil size should normally be equivalent to that seen in the direct light reaction and is graded on the same numeric scale. Repeat steps 1, 2, and 5 in the left eye. Performing the swinging flashlight test. Under dim room illumination with the patient fixating a distance target, illuminate the patient's right eye directly with a bright handheld light, in a manner identical to that used when testing the light reflex. Note pupillary constriction in both eyes. Move the light beam immediately and swiftly over the bridge of the patient's nose to the left eye, noting the pupillary response in that eye. Normally, the pupil will either constrict slightly or remain at its previous size. Quickly swing the light back to the right eye to evaluate the response. A normal response is again a mild constriction or no change in size at all. Net pupillary constriction or dilation is an abnormal response. Repeat steps 1 to 3 rhythmically, spending equal intervals illuminating each pupil until it is clear whether pupillary responses are normal or whether one pupil consistently dilates. Record a relative afferent pupillary defect as 1+ to 4+, 1+ indicating a mild defect and 4+ indicating an amaurotic pupil.
Visual field examination. The visual field is that portion of the subject's surroundings that is visible at any one time. The visual fields are routinely screened with a confrontation fields test. If macular disease is suspected to be causing a central visual field defect, a device called an Amsler grid is used to test the central area of each eye's visual field. If a visual field defect is detected by screening, further evaluation is conducted by manual or automated procedures known as perimetry. For our purposes, we shall mainly focus on the screening procedures. Performing the confrontation visual fields test. Seat the patient and make sure the eye not being tested is occluded. Seat yourself facing the patient at a distance of about 1 meter. Close your eye that is directly opposite the patient's occluded eye. Ask the patient to fixate on your nose or on your open eye. Finger counting. Hold your hands stationary midway between yourself and the patient in opposite quadrants, about 30 degrees from fixation. Quickly extend and retract a finger or fingers on one hand in one quadrant of the monocular field, asking the patient to state the number. How many fingers do you see?
2.
How many?
1.
How many fingers?
2,
How many fingers?
1,
Okay. To avoid confusion, limit the number of fingers shown to 1, 2, and 5, and hold the fingers side by side in the frontal plane. Repeat in all 4 quadrants, testing at least 2 times per quadrant. How many fingers do you see?
1,
How many fingers do you see?
1,
How many?
1.
Test patients who have marked visual field loss by waving your hand in each quadrant, individually, and asking if the patient perceives a motion. Do you see the motion?
Yes, sir.
Do you see the motion?
Yes, sir.
Testing young children with a finger mimicking procedure. First test the child to hold up the same number of fingers as you do, then conduct the test as usual. We now go to simultaneous finger counting. Present fingers simultaneously in opposite quadrants, asking the patient to state the total number, using the following combinations: 1 and 1, 1 and 2, 2 and 2, and ask the patient to add. This test can reveal a more subtle field defect than finger counting in each quadrant separately. Can you count and add the number of fingers you see?
2, 3, 3.
The slit lamp biomicroscope is a unique instrument that permits magnified examination of transparent or translucent tissues of the eye in cross-section. The slit lamp enhances the external examination by allowing a binocular stereoscopic view, a wide range of magnification, and illumination of variable shapes and intensities to highlight different aspects of ocular tissue. The slit lamp is indispensable for the detailed examination of virtually all the tissues of the eye and some of its adnexae. It is routinely used for examination of the anterior segment, which includes the anterior vitreous and those structures that are anterior to it.
Performing digital tonometry is one way of estimating intraocular pressure, and this is an integral part of the eye examination. Though this may be subjective, it can be performed in the absence of proper instrumentation and on uncooperative patients. However, this procedure is prone to error even in the most experienced hands. First, ask your patient to look down with his eyes, not moving his head. Please look down. Next, put both 4 fingers on the eyelids, making sure that pressure is on the scleral side of the globe. To ensure stability, anchor the other fingers on the forehead. Alternately, apply pressure on the globe with both 4 fingers, making sure that it is not lifted from the globe. Again, instruct your patient to keep his gaze looking down and assess the opposite eye. A more objective means of assessing intraocular pressure would be the use of the Schotz tonometer. This is your standard Schotz tonometer, and its basic parts are your scale, 2 arms, the plunger, and your pressure plate. In performing Schotz tonometry, the examiner should make sure that the dominant hand has a good hold on both handles, wherein the thumb and the 4 fingers are positioned in such way. When performing the examination, you must not forget that the scale must be facing the examiner during the examination. This procedure is done with the use of a topical anesthetic. Make sure that your patient is positioned in a semi-reclined position with his head almost horizontal, and instruct your patient to fixate on the ceiling while you perform the examination. Firstly, apply your topical anesthetic. Look up. Ask your patient to close his eyes gently, without squeezing, to allow proper absorption of the topical anesthetic. Give it a few seconds to about 2 minutes for the anesthetic to take effect. This will ensure that the procedure is done without any unnecessary pain and discomfort on the patient. Then you may proceed with shot stonometry. Ask your patient to open his eyes. Position your fingers on the shot stonometry in such a way that your thumb and forefinger are on the arms of the tonometer. Ask your patient to look up at the ceiling. Open the eyelids and assist your patient, making sure that no extraneous pressure is placed on the globe. Apply the foot plate on the cornea and take note of the reading on the scale in front of you. Ask your patient to blink once and perform on the opposite eye, again making sure that while assisting the patient in opening his eyes, you don't exert extra pressure on the globe.
Applanation tonometry is one of the more accurate methods of measuring intraocular pressure. Its basic principle is the flattening of the cornea to an area corresponding to 3.06 millimeters, and the attendant flattening is reflected in the dial in the machine, which corresponds to the intraocular pressure. Unlike the other forms of intraocular pressure measurement, applanation tonometry uses fluorescein dye, and the Myers in the machine are best visualized under a cobalt blue filter, as will be demonstrated later on. Performing Goldman applanation tonometry. Insert a clean tonometer tip in the biprism holder. Instill a topical anesthetic drop in fluorescein dye into each of the patient's eyes. Seat the patient at the slit lamp with the patient's forehead firmly against the headrest and chin comfortably with the chin rest. The patient's eye should be aligned with the black band on the headrest column. Instruct the patient to look straight ahead and to open the eyelids wide. The examiner should be seated facing the patient behind the slit lamp oculars. Position the cobalt filter in front of the slit lamp illumination device. The cobalt blue light causes the fluorescein dye on the patient's eye to fluoresce a bright yellow-green. Set the magnification of the slit lamp at low power with the light beam at high intensity and shining on the tonometer tip at a wide angle. Looking from the side, use the slit lamp control handle to align the tonometer tip with the patient's right cornea. Adjust the numbers on the tonometer force adjustment knob to read anywhere between 1 and 2. Instruct the patient to focus on your right ear, blink once, and then try to avoid blinking. Using the slit lamp control handle, gently move the biprism forward until it just touches the cornea. Looking through the slit lamp oculars, confirm that the biprism has just touched the cornea. Raise and lower the slit lamp biomicroscope with the control handle until the semicircles are equal in size. The semicircles can be viewed monocularly through only one of the slit lamp oculars. Slowly and gently turn the force adjustment knob in the direction required to move the semicircles until their inner edges just touch and do not overlap. With the slit lamp control handle, pull the tonometer biprism away from the patient's eye. Note the reading on the numbered dial and multiply the number by 10 to obtain the intraocular pressure in millimeter mercury and record the pressure in the patient's chart. Repeat the procedure for the left eye.
Techniques in doing direct ophthalmoscopy. The patient is examined in a dimly illuminated room. As much as possible, a fixation light is provided so that the patient does not look at the ophthalmoscope light. It is preferable to examine the patient while seated. The examiners examine the patient's right eye with his own right eye and the patient's left eye with his own left eye. The ophthalmoscope is held in the corresponding hand. The examiner sits or stands on the side of the eye being examined. The head of the ophthalmoscope is steadied on the medial superior margin of the examiner's bony orbit. The examiner's index finger is used to change lenses. The red-orange reflex is checked from a distance, after which the examiner slowly approaches the patient. The ophthalmoscope is focused by shifting the dial until a clear image of the fundus is obtained. The patient's optic disc is examined first to assess the cup-disc ratio. The optic disc is followed outwards to examine the superinasal, superotemporal, inferonasal, and inferotemporal areas. Vascular color, caliber, bifurcations and crossings are noted, as well as hemorrhages and exudates. The macular area is always the last to be examined to avoid photophobia. Any abnormalities observed are noted. The entire procedure is repeated on the other eye.
The indirect ophthalmoscope consists of a headset with a binocular viewing device that optically reduces the examiner's interpupillary distance and an adjustable lighting system wired through a transformer power source. The examiner positions a variety of convex handheld lenses called condensing lenses close to the patient's eye. From an arm's length distance, the examiner examines the patient's fundus, preferably through a dilated pupil. The indirect ophthalmoscope provides a stereoscopic wide field of view, 40 to 50 degrees, allows examination of the retinal periphery, and makes it possible to penetrate hazy media. Indirect ophthalmoscopy is possible to perform with the patient sitting upright in the examination chair. However, if the examination will take longer than a few minutes, or when scleral depression is to be performed, it is easier with the patient supine. The examination room should be dimly lit, and the ophthalmologist should be dark adapted. The headset should be positioned comfortably on the examiner's head. The eyepieces should be situated as close as possible to the examiner's eyes, perpendicular to the pupillary plane without touching the bridge of the nose. Adjust the interpupillary distance of the oculars to allow the examiner to have a comfortable binocular view. The light beam should be adjusted vertically until the light beam occupies the upper half of the field of view. Ask the reclining, fully dilated patient to gaze steadily at a distant target on the ceiling. Patients with poor vision are asked to extend an arm and stare at their outstretched thumb. While standing above the patient, direct the headset's light by tilting your head so that it illuminates the fundus when focused through the condensing lens. Hold the condensing lens in the standard manner, position it just in front of the patient's eye, and center the pupil in it. Focus the lens by moving it upward and downward until you see a stereoscopic focused image of the fundus. Accommodate on this image with both eyes and maintain it by keeping the headset's light in the patient's eye. Examine all areas of the fundus, doing scleral depression if necessary to examine the far periphery of the retina. Make the fundus drawing as you go along in your examination.